Welcome, everybody. My name is Norm Jacknis. I'm Senior Fellow at the Intelligent Community Forum. I'm also on the faculty at Columbia University, and I'm very pleased to be here with the guests we have tonight. I've been to Taiwan, been very impressed by the country and its advanced healthcare system. And health, in fact, is considered to be a right available to all people there. And they've used those considerable skills that they have in the country to advance the quality of healthcare. This has been particularly evident in their handling of the COVID pandemic. When I checked just a few days ago, they have had a total of 7 deaths, just 7 deaths among their population. And they went for a period of 200 days without any new infections among their own people. The infections they have had have been basically from visitors who came there having brought the disease with them. So there's a lot to learn for the rest of the world to learn from Taiwan's experience and skills. And the healthcare solutions that have come out of Taiwan have actually been quite impressive, which is why we have 2 of their companies here with us for this session. One is called Merits, and they will explain what they do in a minute or two. The other is Health Inventor, and they will also explain what they do. In addition to the health companies, however, we have 2 American experts. We have Pat Schou, Executive Director of the Illinois Critical Access Hospital Network. This is the first American statewide critical access hospital network around. It was established in 2003. It has 57 critical access in rural hospitals, and it's providing hospital support services and educational programs all across the state. Our second expert is J. David Liss, who is president and CEO of J.D. Liss Associates, a strategic advocacy and communications company focused on healthcare. And prior to that, he was vice president at the New York Presbyterian Hospital, one of the most famous in the U.S., and I guess currently ranked number 4 in America. And then also vice president at BioReference Laboratories. And he has, over the course of his career, been a leader in health IT. So it should be an interesting discussion going forward. But let's start with the companies, and let's start with Merits. If you could first tell us a little bit about what your company does, it would be helpful.
Sure. Thanks, Norm. Merits Health Products have been built since 1986. So we've been in business for 34 years. We mainly build for mobility products, things like rehab power wheelchairs, scooters, drive-only power chairs, manual wheelchairs, patient aids, rollators, walkers, things like that. So we have been in the mobility world for quite a while.
Interesting. So how would you describe the benefits, particularly for people to be able to sort of re-enter, if you will, society, or at least navigate around it from what you offer? Can you give us some examples, some stories, perhaps?
Yeah. Maybe allow me to separate this into with IoT device or before IoT device. Before IoT device, actually take the rehab power chair, for example. Actually, the device itself help the user, the patient, be able to freely maneuver around, drive around. So instead of stay home, stay on the bed, they be able to drive themselves wherever they want to go. Also not depending on the caregiver. So give you the other example, the rehab power chair with that lift function. Usually people that sit on a wheelchair, they tend, because of the height of the seat, the nature, they have to lift their head and talking to the normal people. But with that lift function, they be able to, with the same eye level, and they be able to pick up stuff from the shelf, from the kitchen. So that device actually already helped them get back to the society in certain way. But with IoT device help, it actually, from my perspective, I saw this application connect them with different stakeholders. One as the physical therapist that usually prescribe them the chair, but they actually would care about how they're being positioned, so their body don't bend, so that affect their health. So IoT device be able to connect them with therapists. IoT device also help them connect with the caregiver. Some caregiver may not live with them. They live, say 10 minutes away, even more far away. But the relatives or family be able to get to know some information of the chair or even the users himself. So that's the other group. And the third group is the dealer, the service provider. In US, usually when a power chair broke, it would took them about 3 weeks to fix it. And we are all normal people. But think about if your leg broke and you have to stay in one place for 3 weeks and not going anywhere. That's a big hassle. But with IoT connection, I think we'll be able to significantly shorten that waiting time. So that kind of give you some idea about how our topic today be able to help them reconnect with different part of the society.
So IoT, the Internet of Things, can cover lots of different kinds of devices.
Yeah.
What kinds of things are you using specifically? Is there sensors there? Communications devices? What exactly do you have that you're making that's part of the solution here?
Yeah, now we have two major sensor. One is more of the mechanical sensor that be able to detect, the chair, how the motor turns, how much of the battery is left, and where the chair is, and also even include how many miles or what's the range have been traveled. Those kind of information. The other side we call it I should say more like a human sensor, but we particularly purposely developed the seating pressure sensor, because based on the study from University of Pittsburgh, there's about close to 40%, I think the exact number is about 39 point something percent of the people that using wheelchair for long time, say they need to stay on there, no matter it's manual or power wheelchair, if they need to stay on that type of chair, that type of device for whole day, then about 39, close to 40% people will have the ulcer issue. And once they have the ulcer, it would significantly affect the whole medical system. I think the two doctors, they are all linked to the top-notch hospital. They would have that kind of experience about how things could turn south when the user start to affected by the ulcer. So that's why we kind of purposely designed that seating pressure sensor and connect to the internet so we be able to tracking how the people the central, how they move around the whole day and how's their pressure accumulation. So that would help the physical therapist decided what help they can provide, or what kind of suggestion they can provide to the user. And even because with more information feedback, they be able to give more precise advice to the user.
Very clever, very clever. I'm curious. This is relatively new, though, in the field of mobility and healthcare. What do you expect would be the global market for this kind of thing? Do you have a sense as to how much this would expand in the future?
We can put it two ways. The optimistic way will be with the, almost all the countries, especially the developed countries. All the developed countries are talking about the aging society. The elder population is getting larger and larger, especially like U.S., even Taiwan or Japan, or the West Europe. So that means actually we are all the population are requesting higher and higher, demanding higher and higher care capacity, so to speak. But with the pandemic and the draining the financial capability of the country, I think there will be a trend, a big trend that people need to stay their home. They like to stay their home, actually. They're not willing to be sent to a nursing home. But with the limitation of the government financial, there will be more and more demand coming out that requires, you need to find an economy way, but in the meantime, be able to take care of this aging society. Okay, that's the optimal side. I look at this. The practical side, I have to say, even with considering the US and the Europe reimbursement regulation, IoT is more, to me, is more like a tool. Okay, but how you adding value to the user or adding value to all different stakeholders is very, very important. But even we try to add value to all the stakeholders, at the end of the day, the success of a development, a technology development, usually rely on who's going to pay it and what's the budget. So I would suggest, if not just US, but all the countries, the insurance company, all the important player, the insurance company, in US, more like Medicare, Medicaid, all the government, I should say, legislation should start to consider to put this into their, in US, we call it PDEC code, things like that. They have to put this kind of IoT device into that. So start to more like encouraging the industry put their energy to develop this, because even we can talk about the values all day long, but if there's no really business coming out or as a result, then it will hinder or be a big barrier to the development of the IoT device, so to speak. Yeah.
Interesting. Okay. Where do you see this going 5, 10 years from now? What are the related products or services that your company is planning or that you see happening? I'm just curious, because this obviously is a lot of potential here, and I'm assuming the cost of devices are also going down as well, so that helps.
Yes.
So just what's your vision of where this will go?
Yeah, I would foresee we will put down more and more mobility products, or you call it accessibility products. Things like power chairs, scooters, even some the lift, the porch lift or stair lift, any type of the device that in our industry even call it like home remodeling, that help the aging people to live at their home better and longer. So if you can imagine because we had less and less young generation, so less and less caregiver. In the meantime, we need to cover bigger and bigger population of the aging population. So if there's an IoT device that can put at home that help the caregiver be more efficient, or help the stakeholder be more efficiently cover more aging population, that would hugely benefit not only the medical system, but our society. So I would foresee 5 years from now, you will see the IoT device, if not quadruple, at least double or triple, from now, I would say.
Interesting. The idea of including this in the home is a fascinating one. I remember hearing a discussion, I guess, not that long ago, about the use of IoT devices to detect falls when somebody fell down, and a whole variety of other things when the caregiver's not there, but you really still want to be able to track the health of somebody who's trying to live still at home and not go into a nursing home. Interesting. Are you in North America? Is this being sold in North America now? What your company offers?
Yeah, we did have, I should say, office, a distribution office in Florida, in Fort Myers. Yes.
Sure. Okay. It's still there now, or?
Yeah.
Okay.
We're actually growing significantly. Yes.
Well, I guess there are actually a lot of senior citizens in Florida. That's probably a good location. Interesting.
That's one of the reasons. Yes.
Okay, and we'll come back to you. I wanted to go next to Health Inventor and Dr. Dyna. Are you? I see you're with us. Can you talk?
Yes.
Okay.
Hello.
First explain a little bit about what your company does.
Yes. Health Inventor is a startup company, so it started from the 2015, and I just come back to Taiwan 2 years ago. So I was acting the CEO right now in Taipei, and we also have another branch in Shanghai, Hong Kong, and also 2 branch office in Taipei and Taipei County. So we are more focused on using high-tech technology to create new services to help the people can improve their quality of life. So that's why we build up the healthcare platform, and we also integrate lots of the devices, IoT devices, just like the blood pressure, blood glucose, and to help the people can monitor their sensor and the body of the health in their home or any organization. So we are more focused on the build up the new service engine or the risk assessment engine, just like the chronic disease. So we can help the people based on their BMI, body weight, and the blood pressure and the ACO A1C to assess the people, the trend and the disease pathway. So that's what we are doing now.
Interesting. So is this a piece of software that the person uses at home, the individual patient or person? What are they? It is. So what they're seeing something as an app of some kind?
Yes, there are 2 main different solutions. For some solution, you can start from your wearable devices or the IoT devices, so we can collect the data in their home. And after that, when we collect lots of the data, we can do the analyze. And we also have the bigger data bank to simulate, to do lots of the patient similarity model. So we can simulate the people after the 5 or 10 years, what will happen. So when the physician can get the answer or the potential way, we can engage with their quality of health. For example, we can change your health plan. We can give them the exercise program. We can help them to coming back to avoid the comorbidity. So we are trying to use the first one is collect lots of the data from their home or body of the health information and to do the analyze and to get back to the physician. So that's one of the solutions. So we use the web services, we use the mobile devices, we use lots of the AIoT or IoT sensor devices. So this part of the first one solution. And another one solution is more focused on the hospital. So this year, early of this year, the coronavirus is very important thing. So we have the one dashboard, and that dashboard can real time to collect the patient information or the quarantine the place. So even the people, they don't have any fever, but they have some health symptoms. So we can analyze the symptom and to collect their blood pressure, and to even to consider about their health history. So some of the quarantine patients who live here, we already sense their BSRS, that's moon services, and the quality of the services. So we can help them to understand what the pressure they are facing and how to help them to move another place. And after the 14 days, they can go home. And we also need to monitor the status or the fever after they staying home. So that's another solution. We use the dashboard built in the cloud platform.
So these are for people who have COVID symptoms, and you're tracking them, not just helping them to understand what the symptoms mean, but then afterwards as well.
Yes.
Interesting. So the primary customers for this are the individuals. Where do the medical providers come into the picture?
Some is in the patient in hospital, and we also work with the Taipei hospital, and we have the 8 hospital collaboration model and program. So in past maybe the 6 to 8 months, we also support around the 1,000 of the people who live in the quarantine place.
So are you focused just on the people with COVID symptoms, or this can be used for anything, I'm assuming, right? Not just COVID, correct?
Yes, but not only for the COVID, because we also consider about their chronic disease. Because when the people, they live in the quarantine station, maybe they have the hypertension or the diabetes, but they cannot go to take the new medicine. So that's why we also need to monitor and help them to check the body health. So even when they monitor or report the coronavirus status or the symptom, we also need to consider about their traditional the status, health status.
Interesting. I'm assuming you've been growing a lot during this period of time. The company has been growing a lot, right?
Mm-hmm. Yes. Mm-hmm.
Has there been interest on the part of governments in distributing this and sort of making it available to their residents?
Yes, because sorry.
No, I'm sorry. Go ahead. I was curious whether or not governments and public health officials have come to you and asked about distributing it more widely.
Yes, because these things we work with the central government and the local Taipei city government because they need to adopt the policy and the regulation to help the patient. So that's why the patient, when they into Taiwan, come to Taiwan, and we need to monitor or the track where they go and what is the people who contact. So it's very important to work with the hospital and the local government.
Interesting. Have you, obviously this is important anywhere in the world. Have you had interest from North America and Europe where COVID has actually been much worse than in Taiwan?
Okay. Yes, because we are a new startup company, so we have the 5 years journal plan. And for the first 2 years, we do lots of clinical trial, and we publish a lot of paper in the related just like the diabetes care. And for the another 3 years, we want to do the localization because the chronic disease or lots of the diseases need to monitor their life quality and the personal behavior. So we all around the patient or people-centric services. We do lots of the time and services to help the people collect their data. And we also spend lots of time to using this data and to provide the visualize the chart and the visualize trend and to analyze what the pathway that could be. So we provide the feedback to the physician. So in another 3 coming years, we will help the different country, for example, in China or in the American, because I still have lots of the chronic disease over there. So we want to help the people can do their self-efficacy more better. So we use the devices, we use the cloud platform solution. So I think the place is not a big issue to us. But I think the North American is very important to us, and we like to do that.
Interesting. Well, also, I think if you extend this to other parts of the world, you'll also get more data from different demographic populations that may help as well, right?
Yes.
But you haven't had any, has anybody actually asked you from the governments in North America or Europe so far?
Yeah, in America not now, but in other places like China, there's a lot of requests for us. Yeah.
Interesting.
But we're happy to do that.
Well, the ICF has a global audience, but a lot of the people are in North America and Europe, so that's why I'm asking about that. The people who would be hearing about this. Interesting. And where do you see this going in the next 5-10 years? What's your vision of where you can be using this and how you would expand this, given changes in technology and for that matter, changes and advances in machine learning?
Yes, I think it's very important in coming 5 years because the people will use the wearable device even just like me, and you collect lots of the data. You also want to monitor your exercise and you want to understand your body inside. So we collect lots of the big data and we do the simulation model, and we want to help the people can getting better. So I believe there are lots of the medical devices will go to market, and we can integrate that devices into our cloud platform. And in fundamental, we also integrate with the IBM Blue Mist cloud platform and the Google Health Cloud. So it's very important to do the new ecosystem in the worldwide. So that's why I think in coming 5 years, it's very important to change the people's behavior. And it also will change the patient's behavior. For example, just like diabetes, we use the glucose meter for the BGM, but now for 2 years ago, we have the CGM. CGM, that means we can detect your body clock within the 24 hours. So that will change the behavior, and it also will change your patient engagement model. So I think it's very important to us and also to the worldwide in coming 5 years. Yeah.
Interesting. Okay, we're going to have more questions, but I want to go to our two American experts, if I can, and ask you some questions. So this is communications two ways. You'll get a chance to ask them questions, but first we want to do a little transfer of knowledge in the other direction too. So I've got a couple of questions for both of you. I guess the first is, what do you think has been the most revealing weakness that you've discovered in the healthcare system as we've worked on this over the last year? Do you want to start, Pat?
I guess I'm unmuted now. Can you hear me?
Yeah,
okay,
we can hear you. Yes, you can.
Oh, gosh. Well, like I said, I thought we were ready for any kind of pandemic, but we really weren't. Yes, the weaknesses is that really we had not taken a good hold of telecommunications and being able to work with people in their homes. I mean, telemedicine and all that has been around for 20, 30 years, and yet we had not advanced it to where we needed it. And it brought us front and center with the COVID experience. And we've had to learn very quickly. And I thought that was really a tremendous weakness. We could have been much more prepared for that and had places, we had clinics and physician groups go out and all of a sudden get off the internet and apps so they can do DoxyConn and all those things just to be able to do telemedicine, and yet without a lot of training and preparation. So we also know that, you mentioned the comorbidities in North America with its health, in our rural communities in North America or United States and particularly, and in the Midwest and the South, is that we have a greater percentage of elderly with comorbidities. At least anybody over 65 has 2 or 3 or more chronic diseases. And we really aren't prepared. I was listening to Dr. Chao talking about, being able to monitor them in the home and so forth, and really develop the infrastructure so we can care for people in the homes. Now, I'm seeing a lot more come out of our government and agencies and think tanks about more care in the homes and using our sensors and technology that you're talking about, because that will help to reduce costs. So technology-wise, we really weren't prepared. We realized that we really struggle with some of our chronic diseases, and we need to begin to blend and start looking what we can do to take care of them in the future. And it really also focuses on one of the things that we're struggling right now is the connection of primary care with specialty. We've got problems in our rural communities. We can't transfer patients for specialty care because our hospitals are full with COVID patients. And so, it's made us think about, okay, well, if we can't transfer to specialty care, how can we use our telemedicine, our specialists, and things like that to bring things home that we can manage more locally? So I hope that gave you a little insight into, what's going on in rural communities in U.S.
Yeah, and it's interesting that you talked about communications because both of these Taiwanese companies are actually dependent on good communications.
Absolutely.
What they're talking about. David, what's your answer? What do you think has been the most revealing weakness that you've observed in our health system over the last year?
Because there was a failure to create a single unified strategy, a national strategy that covered all of the states, there was a large quantity of tools that could have been available to us that we didn't actually make use of. I'm thinking about the response to avian flu, which we had 2 years ago. And like you, Norman, I'm on faculty at Columbia University. I'm in the Department of Biomedical Informatics. And I'm thinking about what the national response to that was, where we were able to start collecting data and create an analytic model because we were getting drug data, prescription data, ordering data from a variety of settings, traveling from New York City, where the avian flu began, the Hudson moving west. And so as we saw sales data for flu-like medicines that treat flu-like symptoms come in, it clued us to look for other tools. There was a very tight level of coordination that came from both the CDC and from the FDA, so that there was a variety of tools brought to coordinate to really get ahead of the disease. What we needed was a national strategy that would allow the best and brightest parts of the U.S. to take what they had in terms of technology and public health knowledge and take that data. For instance, when we found out that Theraflu sales were going up, when we found out that flu medicines were going up, we were able to then focus in and collect from hospitals hemodynamic data. So now we're finding out that more and more patients are being admitted to the ED with high temperature. All right, well, that clued us in to look for more information. But because there was a level of coordination, we could do that. So from my perspective, the lack of coordination prevented us from combining the tools and resources that we had to get ahead of the disease.
Interesting. Okay. Yeah, it also makes it more difficult to widely distribute innovative ideas in the short run as well. So, So looking a little bit further, we hear about vaccines, and everybody is hoping that maybe by September 2021 we will all be able to come out of our caves. And aside from Pat, who's already obviously successful at that. But we hear about that. And so the question is, what do you think is going to be the most significant change as a result of what we've gone through with COVID, the most significant change in the healthcare system and the way we go about managing people's health? Pat, do you want to start?
I really think that the COVID has made us think twice about our infection control practices and about how we communicate and work with other communities and other providers. We really, even though we have good infection control, we have antibiotics, we have antibiotic stewardship and a lot of things like that, but we really hadn't on that day to day. Yes, we have sanitizer and things like that, but I really think it's made us think about diseases and how we should be respectful to others and have good practices in place. I even think it's waken up the general public and made them. And so I think that's been a major accomplishment. I think we've gotten lax over the years, and maybe, taking from David, the strategies that we just didn't move those strategies forward. So I think that's going to be very concerning. I think it's going to make people pay more attention to their personal health. And so I was appreciated hearing about our two companies in Taiwan that are really working on ways to better it. And the third thing is, I think it's going to really, once again, going back, how can we care for people in their homes and not just hospitalize people, but how do we treat and prevent? And so infection control, practicing, connecting the dots. I think we're going to be just a little step ahead of the game next time. And I think that's what we've learned. We have to be more prepared and use our tools and, day-to-day practices and continue our awareness building with the general public and have them take greater. We're still seeing people not taking responsibility, wearing masks and other kinds of things like that, or not going in for health care. But we also have to learn how, if we have the virus still around there, how do we live and how do we continue to take care of other diseases? We have people not coming in for breast exams and other things like that. So how do we learn to live and move on, protecting society, protecting others, but yet being more responsible for our personal health?
Interesting. Your comment about the hospitals for people who are outside of the United States or parts of Europe, and they may not realize that right now with COVID, a number of our hospitals have reached their capacity or even beyond. So anything you can do to provide care for people that doesn't require them to be in the hospital facility would help in this kind of situation. And possible future situations like this. David, what's your view of the most significant changes you expect after we finally get past this pandemic?
I think that we're going to see significant changes, and I in some ways I think they're going to be rather positive. So we're going to see payment change on the part of CMS, and that's going to be a good thing. We've been talking about using technology and using data to manage the individual's health. But if you look at where the real problems were in this pandemic, the real problems were everywhere, of course. But if you look at the greatest concentration of problems, it was in communities of need. It was in communities, social determinants of health have long been at risk. Pat was alluding to this when she was talking about obesity and chronic illness. COVID really blew that up. And so the question becomes, how do we go into populations that won't be wearing a Fitbit, that won't have an Apple Watch, and find some ways of bringing them into the data ecosystem so that we can start getting ahead of it? And I think that there are answers to those questions, and I think that payment is going to start rewarding answering those questions. So I'm kind of excited about where we can go.
Interesting. So I've been asking our Taiwanese companies about what their vision is going out 5 or 10 years. I'm going to ask the two of you this, the same thing. What do you think will happen over the longer term? What's significant? Both challenges and changes, going not just after, in 2021 when we get past the pandemic, but going out a few years. Pat, what do you think is going to happen?
Well, obviously, I mean, I continue to carry the theme that we all are with technology that, will play a very, very important role. And we hope that the payment follows the move to more self-care. David alluded to those populations that really don't have financial support or not access to some of those things and how we're going to prove it, but the continued focus on population health. I'd like to see us continue our efforts to decrease our silos. I still think that we have a lot of silos in healthcare and bridge with our social determinants. And I think our payment systems have to really blend with that, and we haven't done a good job with that. I think the education system, as far as health professionals need to change. I think we need to continue our efforts with proactiveness and prevention and understanding data analytics. I mean, years ago, physicians were trained just, they have scientific background, but they weren't always using analytics in day-to-day care. And now we have that available, and we have to learn how to use that and make better decisions based on that. I think we'll look at chronic diseases, more care management processes. Scientific breakthroughs have come all the way along, and I've watched it over the decades, been in healthcare for a few years, and now it's time for the person. How do we improve self-care? How do we improve our populations? Because if we can't do that, we're not going to control healthcare costs, nor are we going to improve, with chronic diseases. We've got to learn to keep people healthy, and we have to begin to incorporate mental health. I mean, we've got social determinants, but that mental health picture And we need to have resources to better manage those things. And I hope to see that that will come about, you know, the whole person, the self, in the next 3 to 5 years. As long as the payment comes along with that, that's going to have to be very critical for success and making it and us being good stewards with that.
David, what's your view going out 5, 10 years of what the biggest challenges are and opportunities and actually changes that you actually reasonably would expect?
Well, I'll talk about that, and it's not hard to connect what we're hearing from the two companies in Taiwan with what the next 5 years is going to look like, actually. So let's start with some things that are actually happening now, which can indicate where the future is going. Some things that are subtle. For example, Congress in the United States, Congress recently passed a law the president signed, changes in the Stark and anti-kickback laws. Now, what does that mean? The Stark laws are about physician self-referral, anti-kickback. So a physician who, for example, owns a hospital, it has to jump over some high hurdles in order to refer a physician from an outpatient practice to the hospital that he owns. And that's appropriate because you want the system to be honest. Anti-kickback laws exist because you shouldn't be able to accept payment for getting service, payment for a patient. So you can't pay a patient, for example, to come to your practice. The problem with those very good laws is that as the world changed, as payment followed different models like bundled payment, where you would get a single amount of money for a number of services provided in different settings. Accountable care organizations, again, where patients were assigned to groups of providers who then divvied out payments. It became more and more difficult to follow these processes in looking at Stark and kickback and anti-kickback. Well, Congress changed the law to make it easier to take care of patients across multiple settings and to have money flow across multiple settings. That's a major step that indicates coordinated care and where it's going. Another example of what's going to change, I think there's a project that we at Columbia are very familiar with called the Observational Health Data Science Initiative, Odyssey for short. And what is Odyssey? Odyssey is a project that has collected 600 million patient records, electronic patient records, from across the entire world, all of the academic centers in the United States, academic centers across Asia, across Europe, in Australia, in Southeast Asia. This project is extraordinary because it took 6 or 7 years for us to figure out a methodology that allowed us to query across these different electronic formats. But we did it. And now we're answering questions that we could never have answered before. Does drug A, which is for diabetes, have an impact on cardiac care? Well, the clinical trial that you'd need to put that together would take years and millions of dollars. That's an actual question, by the way, that Odyssey answered, and it took about 2 days and cost nothing. Well, I mean, building the infrastructure cost a lot, but now to answer a query cost nothing. That's an incredibly exciting thought about how, as data becomes available, it changes practice. And it changes practice quickly, and it changes how research is done. So I think that some really exciting directions we're going in are finding ways of coordinating care by changing the payment models and in having resources we never had before by being able to query against data from the entire world.
Great. I'll point out that a couple of years ago, ICF published a book called Humanizing Data about exactly this kind of thing, that sort of going beyond the use of data analytics purely to be able to sell more consumer products and doing it more for community and public purposes. I'm going to open this for questions in a minute, but I'm curious because both Pat and David raised the issue of cost, and while the United States has a somewhat unusual way of financing its healthcare, cost is an issue everywhere, and even in the UK, which has almost the extreme opposite kind of healthcare system. So I'm curious, both of you are doing things that have the potential to reduce healthcare costs from better outcomes. in the long run. Have either one of you actually been asked to do any kind of cost benefit studies of any kind, or any or that kind of thing? And if you have, what was that like, and what was the reaction that you got? I see, Dr. Chao, you're shaking your head. Do you want to go first?
Yes, I think thanks for the doctor. And I think it's very important to use the telehealth and the devices because, you know, when we can early detect the patient symptom, we can engage early and the cost will be less. So it's very important to help the people understand their situation and the stage. For example, if you have the hypertension and that maybe the risk level is 3, but you also have the early detect of the diabetes, but not the big diagnosis. So how to make sure you can manage yourself easily and healthy. So it's very important to collect the data or live data. So maybe you can collect the body health, body pleasure, and then you also can collect your AC or PC. But after that, we need to understand how to help the people and the physician can do the right thing at the right time in the right place. So in my opinion, I think when we use the data and we analyze the data, we find out the service model for that patient, that's for the individual patient. So when we have the one health program for that individual patient, we can set up a self-goal for that person. And after 3 or 6 months, we can ask them to come back to the hospital and to check their health program. For example, my patient is work on the early of the diagnosis for the diabetes, and after the 6 months exercise program, their AC and A1C is lower than the 5.6. So it's very, even they don't still use the metformin. So it's very important to us. We can help the patient to let them understand how to eat, how to select food, how to eating outside. And it's very important, the knowledge or the education that we need to share to the patient. So that's why I think there are lots of the things we can do for the patient or physician, even in the hospital, so that when we use the telehealth, we integrate a lot of the services, we coordinate a lot of the different organizations. I believe that we can reduce the cost.
Good. I'm going to open up, Pat and David, do you want to go ahead and ask questions of the Taiwanese companies, anything that crosses your mind in terms of what they're doing, how it might be applied in the markets that you're aware of? Feel free. So.
Go ahead, Jonathan. Go ahead, David.
Okay, thank you, Pat. So actually, I mean, a few things come to mind. Actually, the first of us who brought up the idea of payment was Jonathan, and it's very logical that Jonathan, his mind would go directly to payment because DME, durable medical equipment, is a category in Medicare for reimbursement, and DME has had a very tough time, reimbursement, and as budgets shrink, that's only going to get worse. So I have some questions actually for both companies, and thinking about where things fit into the future of healthcare, at least in North America and at least in the United States, where things are going. Jonathan, you mentioned that you do include sensors in your product, but you mentioned 2 types of sensors. One was mechanical, how's the engine holding up? And the other was weight or pressure, correct?
Yes.
So, to the extent, I have a couple of questions. First, by including the pressure sensor in your chair, has that allowed you to expand the definition of what you provide beyond simple DME? Does it allow you to start describing? Did you need FDA approval for that pressure sensor?
Right now, FDA actually don't have that device code for this kind of pressure sensor, so to speak. So before we developed the product, we actually did some market research. There actually already some, but just cushion alone. It's a standalone cushion sensor product built-in. They did try to promote that in a more like kickoff side, but that product actually end up not going too long. So yeah, that's why when we developed this, when we did the market research. Okay, answering your question, we did try to develop our cushion that meet FDA code. Okay, that's the first thing. So at least the DME dealer at least gets something. But in terms of the sensor, that's kind of, it will be the cost on top of the cushion. So that's where the leery or the stress coming in is, or the DME dealer buying in this kind of extra features either on patient's cost or on the DME cost or on my cost. So that's where, how we commercialize this product. When we commercialize these products, that's where the touchy area is. So what our products advantage right now differentiate ourselves is we actually be able to, yes, the dealer will provide a pressure, I should say pressure releasing cushion already, but that pressure releasing cushion actually, if you sit down too long, it will still accumulate pressure to it. But with existing DME code, it actually help, but not help. I should say our pressure release cushion or sensor will help that significantly or significantly reduce the ulcer rate. That's how I think, from my perspective, how I differentiate myself from the existing code.
And I think that makes a lot of sense, and obviously your market research reveals that. But it's not hard now that you've established an IoT interface, and now that you have at least one sensor that's directly related to the patient. It's not hard for me to think about your product as the front end of a diagnostic tool, the front end of a series of patient sensors that in fact could provide, when I speak with physicians about the information that they're looking for, depending on the specialty, they're often looking for certain data streams. They're looking for variation in certain data streams, so that if somebody is in a Merit wheelchair and they know that heartbeat has been steady, but then there's a spike in heartbeat, it gives them indications to be concerned about something else. That's the alert that would be useful to them. And so seeing DME as now the front end of a set of diagnostic tools is something that I think probably aligns with where the future is going. One of my roles is that I'm on the board of an organization called the New York eHealth Collaborative. The New York eHealth Collaborative is the health information exchange of New York State. It's under the responsibility of the New York State Department of Health, and our responsibility is to see data move about New York State, as Diane put it, to the place where it needs to be, when it needs to be, for the purpose of patient care. And what we have good access to is patient record data. What we don't have good access to, what nobody has good access to, is ongoing hemodynamic monitoring of patients outside of the hospital. So I'm very interested in the relationship between the DME that you're producing and its ability to serve as a front end for hemodynamic sensors. And to the point that Pat was making a little bit earlier about mental health, do I want to know if a patient in a wheelchair frequently goes to his front door but then heads back, frequently goes to the refrigerator and heads back, opens the door of the refrigerator. You know, I mean, is there information, or does that, in fact, does the wheelchair stay in front of the TV set for the entire day? For a psychologist, these would be meaningful markers, and having navigational sensors in the DME could provide that information to those who need it. So in terms of what the question I ask you is, what is the relationship between what you produce and using that as a potential front end for both patient hemodynamic monitoring and patient tracking? Obviously, your patients probably don't leave the house, but in the house, there's a lot of movement that could be very revealing. Shall I stop and because I have lots of questions for both?
Well, we only have a couple minutes left, so I wanted to give Pat a chance too. But that's great. No, these are the great questions, and I want the people who are watching this to realize we're just touching the surface with these great panelists. But Pat, we only have a couple minutes. Go ahead.
I'll try to do a couple of questions there for Jonathan there. I mean, I'm really thrilled about the sensors, but I also think that particularly in our rural areas or areas where there's not a lot of technologists, not like an urban area, as we move forward with durable medical equipment and all the hemodynamics and that go with it, we need to look at creating a troubleshooting place, you know, technicians that you can call and be available. They don't want to have to, people sometimes with disabilities don't want to have to call 5,000 miles away or whatever. They want to be able to have somebody that can work with them. So I think that's something to consider, is training for health professionals and how to use the data, you know, our payment systems and the technology to fix it and keep things operating. I think that's very important. And Dr. Chao, I run an accountable care, statewide accountable care organization. I know I'm crazy, but you know, we've learned a lot about healthcare in population and having access to the way you can manage and monitor A1Cs. We know that in 2 or 3 years from now that it prevents hospitalizations or ED visits, and being able to study be able to look at blood pressure control across the continuum of different providers and who's prescribing best and how do they lower it and what are the side effects, that we can apply it to our population health moving forward. We can use the data to improve our outcomes through the technology and the resources that you do. The one thing that we have to be careful is to make sure not only with the technician part, but broadband and internet coverage and people knowing how to use it. So that self-help and training comes along with that. So that's kind of a whole new ball game for another group to add to our healthcare improvements. So thank you.
Great, thank you. I would like to thank all of our fantastic panelists. This has been very informative, actually very encouraging, particularly in the midst of the COVID global pandemic, to hear that there's actually an improved and bright future in healthcare. That's great. And I think it's important that we understand that, as ICF has been saying, communities help each other by transferring this kind of knowledge. And Taiwan has a lot to offer the world. We've only touched on just 2 cases of a way in which global healthcare can be improved by what they're doing, and in the way in which they can learn as well from other people in the world. So with that, I would like to, again, thank you all. And I hope that you have found watching this useful for you as well.